would like to invite our next speaker, who is Professor Frank Jessen from the University Clinic Cologne in Germany. Professor Frank Jessen is the principal investigator, Department for Neurology. His team is engaged in clinical research in Alzheimer's disease with focus on early disease detection, prevention, and treatment. It runs an interdisciplinary memory center with other departments of the University Hospital of Cologne. In addition, the group recently set up the first Alzheimer's prevention registry and center in Germany, which focuses on biomarker-based characterizations and interventions in cognitively unimpaired individuals at risk. A second new focus of the group is a late life depression, for which a clinical research infrastructure has been established at the Department of Psychiatry. His team collaborates with epidemiological, brain imaging, biomarker, genetic, and basic science research groups, and is closely linked to the German Center of Neurodegenerative Diseases. So, welcome. We are very pleased that you are with us, and we are looking forward to listen to your lecture on new opportunities for diagnosis and treatment along the Alzheimer's spectrum.
Thank you very much, Eva. Thank you to Alzheimer's Europe for organizing this symposium and for inviting me. I will carry Philip's talk a little bit now into the clinical practice as we do it today. These are here my disclosures. I also work in many clinical trials and collaborate in different aspects with certain industries. Now, what do we do in everyday work in the clinical practice? So these are the diagnostic tools which Philip discussed, which we use. So when a patient comes to our memory centers, we do cognitive testing, most of the time today still in a very standard, usually paper pencil way. We have MRI to measure atrophy. In this case, for example, you can see here the atrophy of the hippocampus and the red circles. And then we have over 20 years, we have the opportunity to measure the biomarkers which indicate the Alzheimer's disease pathology in the brain by doing a spinal tap and taking the cerebrospinal fluid of the patient and measure these specific biomarkers for amyloid and tau mainly. And we have new brain imaging technologies, more advanced brain imaging technologies, which show us the amyloid PET deposition. We can measure the glucose metabolism, and we can measure tau. So this is basically the set of tools we have today. When you look at this, there are a number of required improvements which we need in the current Alzheimer's diagnostic toolbox, I would say. As you saw, all of these technologies are either in a way invasive or expensive, with the exception maybe of neuropsychology. And this is a big problem, particularly outside of specialized centers and also in many countries. So what we need is biomarkers which show an enhanced availability and also a reduced invasiveness. For experts, the interpretation of the results of biomarkers is sometimes straightforward, sometimes complicated, but for non-expert physicians, the interpretation of the results, particularly in the early stage of the disease, can be very complicated and complex. As Philip mentioned, it's very important to identify the early stages of the disease, and our biomarkers or many markers are not perfectly sensitive to the early symptomatic change, so the cognitive task we use. We want to enhance the individual prediction of risk of cognitive decline by using biomarkers, because this is what is really important for the individual and the family. How is the individual risk of declining in the future? We need better biomarkers to monitor treatments and also to predict treatment outcomes. And as Philip mentioned, we have more than just amyloid and tau pathology, so we need more biomarkers for molecular components of Alzheimer's disease. And I will give you some examples that we are actually on a way towards achieving some of these challenges. One thing which is really coming up strongly currently is a new way of cognitive testing. So as you saw on the first slide, we do in a standard memory center a paper pencil based cognitive testing. Nowadays, of course, we have the possibility to use digital devices for cognitive testing. And there's one strong area of development, and this is basically mobile phone app-based cognitive testing, which the individuals do at home. And we hope that we get more sensitive, particularly early changes, and maybe we can also track effects of treatments better. So this is an example of the Neotive app, which is developed by the University of Magdeburg and the German Center for Neurodegenerative Diseases, where certain tasks which are very sensitive to certain brain functions, particularly of the hippocampus, so very early areas of the disease, brain areas which are affected early in the disease. And we test these and we see that we have very nice correlations with standard paper pencil tests also on these apps. So this is a new developing field where there's also a lot of funding going into this currently from the European Union. I think the most exciting area is what Philip also mentioned, is the development of blood-based biomarkers. So around about 3-4 years ago, there were no blood-based biomarkers. There was only CSF. There were only expensive PET investigations. And actually, very many people in the field were skeptical that there would ever be blood-based biomarkers. But due to technology advances and increasing sensitivity of technologies, it is now possible to measure actually all standard biomarkers of Alzheimer's disease in the blood. And this is one example here of p-tau217, which is a marker for phosphorylated tau. And this is from this paper here, is a correlation within Alzheimer's disease cases with post-mortem tau. So you can see that there's actually a very good correlation between what is measured in blood and what is actually seen post-mortem in the brain of the patient. And this is a typical graph of looking at diagnostic sensitivity and specificity, so quality of a diagnostic test. The more the curve is towards this angle, the better is a diagnostic test. And what you can see is that this is here, that these are here the classical CSF biomarkers, which are of course very good in diagnostic accuracy. But right down here is already this plasma test, one single plasma measure in the blood of p-tau217, actually showing a score of 0.87, meaning a very decent to good actually diagnostic accuracy of just one single blood test for the diagnosis of Alzheimer's disease. So this really expands the availability of biomarkers for the disease drastically. And how can we use these different biomarkers in assessing individual risks? So this is from a study looking at the risk of dementia or of cognitive decline in individuals with either subjective or mild cognitive impairment. And here in this graph, the authors added different components to increase more and more the predictive accuracy for an individual. So the first is the clinical prediction, which is actually quite low and not very accurate with regard to the actual decline the individual will experience. A single blood marker here, p-tau217, is already better than just a clinical prediction. But if you add then, for example, cognitive tests such as memory and executive functioning tests, you get better. Then if you add a genotype, the risk gene of ApoE, you get even better. And then it becomes more and more technical and more expensive. If you add MRI, you get better. And then if you add another plasma biomarker, it gets even better. So you can see that the more markers you use, the better you can actually predict the cognitive decline, but the blood biomarkers are very central here. Philip mentioned that there are many other pathologies, and this is just to show you that there are many more markers coming up. So this is here tau pathology, this is here A-beta pathology, but under development are markers in CSF and blood for inflammation, for vascular dysfunction, for Parkinson's related pathology, for neuronal injury, for other toxicities, for a new, very important maybe protein aggregate TDP-43 for synaptic dysfunction and so on and so on. So within the next 10-15 years, we will see a whole variety of new markers, which we can integrate eventually in the ATN system and extend that to other markers. So this is, of course, very interesting and very complex, as I said, and the question is how to communicate this to the patient. And this is work from the Amsterdam group, so from Philips Center, led by Wiesje van der Vlier. And I think this is a very nice example of how to translate research into patient communication. So this is basically an app where you can put in data from your individual patient from your memory center, including biomarkers, but cognitive data and others, age and gender and so on. And then you get an individual risk estimate of how high the risk is in percent, whether for this individual to develop dementia over, for example, 3 years or 5 years. So in this case, this individual has a risk of 21% to have dementia in 1 year, of 65 to have it in 3 years, and of 83 to have it in 5 years. And then you already have in this app, you have technologies of communicating that risk to an individual, like this pictogram, for example, or these bar graphs. So I think this is where the field is moving to, that we have individual biomarker-based risk prediction of dementia in our patients in the memory center using, as I said, biomarkers and other cognitive markers and other information. Second part is about new treatments. This is a graph which is basically published by Jeffrey Cummings every year, showing the activity of drug development in the field of Alzheimer's disease. And it reads like this outer circle here is phase 1, so this is very early clinical development. Phase 2 is intermediate clinical development, and phase 3 is the clinical development phase just before approval. And you can see that there are actually very few compounds in these circles, and this shows you the mechanisms of action. So all red items here, or dots, are anti-amyloid drugs. There are a few, but what you can also see is that there are anti-tau drugs, which are the blue ones, and all the others, so synaptic, metabolism, inflammation. And what you can see is that there are actually many colors in these circles, indicating that it's not only about anti-amyloid treatment in research in Alzheimer's disease, and also not only about anti-tau treatment in Alzheimer's disease research. Actually, very many mechanisms are being addressed. But when you look here into the phase 3 section, particularly here in the disease-modifying biologicals, so the anti-antibodies, they are all anti-amyloid, indicating that this field is the most advanced of the anti-amyloid antibodies. Now, this is what had been discussed for the last week or so very intensely worldwide, the antibody aducanumab. This is from the initial phase 2 study of this antibody, and it shows that aducanumab, similar to other antibodies, is capable of reducing amyloid in the brain over 1 year here, depending on the dose, but the placebo, there's no reduction, and in the others, there's reduction of amyloid. And in this study, it was shown that not after 6 months, but after 1 year, there was a dose-dependent reduction in the slowing of speed of decline. So this is a clinical measure, and the higher the bar, the more progression over 1 year. And what you can see is that the placebo group had the greatest progression, and the blue one had the lowest progression. So after this, there were 2 big phase 3 studies, which were initially terminated due to a futility analysis, and then there was a reanalysis of the data. This would cover a whole talk, and the findings and the results have been discussed very controversially. I just want to give you basically the result. So on the 7th of June, the FDA approved aducanumab in what they call an accelerated approval. And this is based on the reduction of amyloid as a surrogate marker of Alzheimer's disease. And there's a requirement for a trial post-licensing to establish efficacy. Like I said, there is a lot of discussion whether the decision is right or wrong. And this is to cover, would go beyond this talk. But I think what is very important is that this is actually the first approval in Alzheimer's disease for almost 20 years. So the intense research which has been conducted over the last 10 to 20 years has finally come to a point where we have the first approval of a drug. And I think this is a significant, highly significant milestone in the field of Alzheimer's disease. And I hope, of course, that there will be many others to follow. it's not only about anti-amyloid treatment. There are other interesting approaches. This, for example, is a study where actually plasmapheresis, which we know from internal medicine, is done to basically clear the blood of even moderate patients from all kinds of components, not only amyloid, but probably also other components related to aging, like also inflammatory aspects, and to clear the blood from all these compounds and to basically provide new or young blood. And this seems to actually have some substantial effect on cognitive decline or the prevention of cognitive decline. And this is what you see here, particularly in the moderate patients, that those who receive this plasmapheresis actually stay quite stable here over 15 months, whereas those who receive placebo, they decline. I think this is good news because this also addresses more advanced patients. The mechanism of action is not quite clear, but the effects are substantially large. And there's another approach which is beyond anti-amyloid at present. And this is more for the early stage. This is a nutritional supplement. This study was actually, the lipid diet study was actually funded by the European Union 7th framework. So it's a publicly funded clinical trial where patients with prodromal Alzheimer's disease, so mild cognitive impairment plus hippocampal atrophy, mostly in that study, received this particular nutritional product, which combines a whole lot of components, particularly omega-3 acids and others. And interestingly, over 3 years, so these are now 3 years data, there is quite an impressive and clearly significant slowing of cognitive decline in those who received this nutritional supplement. You can see on these graphs here, the red ones, whereas the yellow ones go down. And interestingly, there is also an effect on the hippocampal volume here. So there's a biological effect as well, that particularly starting from year 2 on, those with who receive this compound have a lot slower atrophy progression than those who receive placebo. So this is also a very interesting approach looking at nutrition. So to summarize, I think that the recent developments in digital testing at the beginning of my talk will improve early diagnosis and disease monitoring through app-based longitudinal testing in the home environment. I think very exciting and really groundbreaking are the blood-based technologies which will drastically enhance access to AD biomarkers. However, we will experience an even very much enhanced need for very good counseling and thoughtful counseling and expert counseling, particularly in the context of early diagnosis and disease cause prediction, because as you all know, Alzheimer's disease is associated with very much fears and worries. So this is important to do good counseling. As I said, aducanumab has received the approval in the USA. It's controversial, but it has received the approval. It's a breakthrough, the first in almost 20 years. But it's important to understand that the field is not limited to anti-amyloid drugs. There are several other mechanisms of action being explored. And I think that for me, at least, I see it that 20 years ago, there were big breakthroughs with the development of the first CSF and imaging biomarkers and the first anti-dementia drugs. And currently, we are at a stage where we see comparable breakthroughs. We see the development of blood-based biomarkers, which fundamentally enhance the use of biomarkers. And we see the first licensing of new medications. But I think this is the time now to also call for, again, substantially increased efforts and investments to take that chance and to really support intense research on this topic in the coming years. So thank you very much.
Thank you very much for this exciting presentation. it was quite clear, but still I think there are some remarks or questions. Are there? I see somebody in the chat. It is Jan again, I think. And he speaks about diagnosis in centers of excellence, such as Frank's or Philips Memory Clinics, is significantly more advanced than in general practice. Which would be the key steps to improve detection in general practice or better referral to specialists? It is a question.
Yeah, I think probably, or one approach is probably the combination of easy to use and easy to interpret cognitive testing at an early stage, for example, through digital app-based mobile phone testing, which provides easy to read results and readouts for the general practitioner, giving him or her the indication that there's maybe something going wrong with this patient. And then we have to discuss whether a blood-based screening for AD biomarkers can be implemented or should be implemented at the GP level. And if this works well, then the GP could basically screen out those who have some cognitive dysfunction due to Alzheimer's disease, or most likely due to Alzheimer's disease, and those who do not have Alzheimer's disease because they do not have the biomarkers indicating this. And those with Alzheimer's disease, they could be sent to the next expert center. I think this would be an ideal way. It will take a long time to establish these types of collaborations, and it will also vary very much between healthcare system from country to country. But I think in general, sensitive, easy to do testing with good to understand readouts for the non-specialized physician, plus easy to obtain screening biomarkers like blood-based biomarkers, I think is a good combination.
Thank you very much for this explanation. And I have to admit, if your lecture was the last or final one, I would ask about multimodal interventions and prevention, but it is the topic of our next presentation. And I see also a remark from Philip Helton. Smart cognitive testing using technology and plasma biomarker are typically ideally suited for the GP setting. I agree. Yeah, thank you. Thank you for your remark. I think it is also the path to the future.